Good afternoon and welcome to today's webinar, The Butterfly in Your Neck, Everything You Need to Know About Thyroid Disorders and Cancer. Later in the program, myself and my colleagues will address as many questions as we can and as time permits. Our contact information will also be provided during our Q&A session. Next, I want to introduce today's presenters. My name is Melanie Goldfarb. I'm an associate professor of surgical oncology and endocrine surgery at the John Wayne Cancer Institute at Providence St. John's Health Center. My two colleagues that will be joining me are Dr. Sarah Redinger, an endocrinologist, and Dr. Rose Lynn, also an endocrinologist who practiced with me at Providence St. John's. My topic today will be thyroid nodules and thyroid cancer. Our agenda, we're going to talk about thyroid nodules, how they happen, what the role of ultrasound biopsy and molecular analyses are in the workup, and how do we manage benign thyroid nodules, followed by some brief information on thyroid cancer, how do we stage, risk stratify, and for really small cancers who actually need surgery. And lastly, when you do have surgery, how do you pick the right surgeon, what kind of surgeries do we offer, and radioactive iodine treatment, who should have it. So thyroid gland and thyroid nodules. In brief, the thyroid is one of the body's most important organs. It can be thought of as controlling the body's metabolism. It increases the heart rate and how forcefully the heart squeezes, and also affects how fast things move in the body, such as food, bone loss, and sugar. Where does it sit? It's just below the thyroid cartilage or your Adam's apple in your neck, and it's about 15 to 20 grams. As you can see, there's a right side and a left side with a little bridge in the middle that sits over your windpipe. You have these two important nerves that sit behind the thyroid that help control your voice, and it's surrounded by important structures such as your carotid artery, your internal jugular vein, and your esophagus. So what are they? They really are just abnormal growth of thyroid cells that happen within the thyroid gland. Most of the time, we have no idea what causes it, as well as most of the time, these nodules are just there and really don't produce any symptoms and generally go undetected. They're very common. About 50 to 70% of adults have thyroid nodules, and the incidence increases with age. And they do happen more often in women than in men. We can feel them in up to 10% of women and in up 4 to 7% of the population. So questions that I get asked: if I have a nodule, do I have to be concerned about cancer? Most thyroid nodules are benign, meaning there are no cancer cells. But the cancer rate is somewhere between 5 and 10%, depending on where you live. Next question I get: do I need my thyroid checked for a nodule? The answer is generally no. The only times we may actually check you routinely for a nodule is if you've had radiation for a disease such as Hodgkin's lymphoma to their head or neck, or back in the day, they used to radiate people for enlarged tonsils, acne, and other things. There are some other rare cancer syndromes that we do also check people for thyroid nodules for, as well as when people have symptoms such as problems swallowing, problems breathing when they're lying flat, a new cough or hoarseness, and a rapidly growing lump in the neck. Incidentally, we also find them commonly when you're getting your carotid checked on PET scans or other CTs or MRIs. So how do we evaluate it? The first and best test is a dedicated thyroid and neck ultrasound by somebody who's experienced, which is either a radiologist, an endocrine surgeon, or an endocrinologist that does this all the time. For us, and for someone like me, it's really an extension of the physical exam, kind of like a stethoscope for a cardiologist. It tells me what the size, the shape, how many nodules you are, and what else is going on in your neck. It also helps me plan for surgery when we need to do surgery. When I'm doing an ultrasound, I look for patterns. So this is a busy slide, but really I look for patterns to tell me, am I worried or am I not worried? And this helps me decide if I think you need a biopsy. And as you can see down here, we pretty much never biopsy for things that are under a centimeter. And depending on how suspicious something looks, we may or may not even biopsy it until it's over 2 centimeters. Or if it's very benign or a big cyst, we may never even biopsy it. What does that mean? As you can see in the picture, it's a small needle going into your neck under ultrasound guidance, where I suck out a small sample of cells that can be examined under the microscope by a cytologist. It's also important to have an experienced cytologist for accuracy. When you have a benign nodule, most of the time this can be observed. The only time I may ever think about rebiopsying you if your ultrasound looks suspicious and somehow it didn't really correspond with your benign biopsy. We'll repeat your ultrasound somewhere between 1 to 2 years after your benign biopsy for up to 5 years to ensure stability. If it's symptomatic or growing, then we may consider an intervention. When you have malignant or cancerous thyroid nodules, the biopsy is accurate almost all of the time, even when it's only suspicious for cancer, but that depends on your institution. So in general, we operate and treat this like it is a cancer, which generally, but not always, includes surgery, and it's important to have a really thorough ultrasound beforehand. When we have thyroid nodules that are indeterminate, meaning that we get a biopsy result that shows some atypical features, but it's not completely consistent with cancer, the risk of cancer is about 10 to 40%. Your options at that time are surgery for a definitive diagnosis, watching it, or doing molecular testing. When we do molecular testing, we really are trying to predict, does your nodule need to come out? And it's only really worth doing if you would be comfortable with not removing your nodule if the molecular testing comes back as benign. We look for specific gene mutations that are found in thyroid cancer or in benign nodules. For certain mutations, such as BRAF, that tells us you 100% have a cancer. Whereas if other groups of mutations are found, then we're pretty certain you don't have cancer. However, if nothing is found, that does not mean that you don't have a cancer. It just means we don't know for sure. Other mutations put you on a spectrum of how risky it is that you might have a cancer. So the other question I then get is, do all thyroid nodules need to be surgically removed? And the big answer is no. But there are two main reasons why your endocrinologist or surgeon will recommend surgery. Number one, and most important, is a concern for cancer. Namely, your biopsy comes back as suspicious or positive for malignancy, or you have a really suspicious ultrasound. Another definite needing to come out is if your thyroid sits below your clavicle and your sternum, meaning it's growing into your chest. Other reasons why we may recommend that your benign nodules be removed are if you're having symptoms such as problem swallowing, breathing, or persistent cough that we're pretty convinced is related to your thyroid. Your nodule increases significantly in size while we're following it. You have what we call a toxic nodule, or that nodule is secreting thyroid hormones, making you hyperthyroid. It's quite big, or cosmetically, you just don't like it that you can see it. Outside of surgery, there's a new technique that is being offered here at the hospital for benign thyroid nodules to try to shrink them, and it's called radiofrequency ablation. And it's for people that have symptoms or cosmetic concerns as a direct result of a proven benign thyroid nodule. Or sometimes for one of those toxic nodules that's producing hormones. Why do we do this? The radio frequency acts like it's cooking the center of an egg, like the yolk, so it shrinks it. And this has been done in Europe and in Asia for the past 10 to 15 years. Here is a chart which shows the results that shows that patients can expect at least a 50% reduction in nodule size. And it's really best for lesions that are 3 to 5 centimeters in size and proves excellent for symptoms and cosmesis. So let's change gears a little bit and talk about thyroid cancer. And for this talk, we're really going to be talking about what most people have, which are papillary and or follicular cancer. So thyroid cancer is one of the fastest growing cancers in America and one of the most curable. This is from the big national cancer database called SEER, which shows that thyroid, as you can see, is like one of the number one growing cancers. And even in death rates, even though death from thyroid cancer is so rare, is up there. Some more stats: 1.3% of men and women will be diagnosed with a thyroid cancer at some point during their lifetime. And this year, there are probably 1 million thyroid cancer survivors living in the US because thyroid cancer patients live long, generally healthy lives. It affects all races and ethnicities, though is slightly less common in Blacks. And although the mean age of diagnosis is 51, thyroid cancer is really the disease of young adults. It is the number one cancer for people ages 15 to 29. It is the number two cancer for women in their 30s and 40s behind breast cancer. And it's actually the number one cancer for men in their 30s. So how do we risk stratify thyroid cancer patients? For most cancers, you talk about stage, and stage talks about a risk of death. What's nice about thyroid cancer is that age is actually important for staging. So if you are under the age of 55, you are pretty much stage 1 unless you have cancer in other parts of your body, and then the most you could be is stage 2. So that's really different than a lot of other cancers. This translates to there being a lot of thyroid cancer survivors. So if you just have disease in your thyroid, you really have 100% survival at 5 years. If it's in your surrounding lymph nodes, you're still at 98% at 5 years, and it dips down to 78% at 5 years when you have disease in your lungs or your bones. So for thyroid, we generally more like talking about what's the risk of the cancer coming back. So we stratify you. Are you low, intermediate, or high risk for your cancer returning? Even very low risk, which talks about small cancers that are very well within your thyroid. There's only one focus of it, and it's nicely encapsulated, are very low risk. Low risk even includes tumors that have multiple small tumors, that have lymph nodes involved, even up to 5 of them, if it's small deposits of lymph nodes. We get up to intermediate risk when we talk about having lots of lymph nodes, palpable lymph nodes on diagnosis, cancer growing outside of your thyroid or for certain mutations. And high risk is with people where it's really growing into other structures, bulky lymph nodes where it's growing outside the lymph nodes or these other structures. What about if you have a really small thyroid cancer, less than 1 centimeter? Small cancers less than a centimeter are typically indolent and don't always require intensive treatment. We also know that these incidental thyroid cancers generally do a little worse if we find them by screening than if we find them incidentally on pathology. So what has been happening and started in Asia, but we are now practicing in the US, is doing active surveillance for small, less than 1 centimeter thyroid cancers. Who is the ideal candidate for this? An older patient with one thyroid cancer and no other nodules, with an experienced team and a patient that seems to be compliant with their surveillance. Who is a poor candidate? A young patient, because they have much longer for these things to grow and change. Something that has more aggressive features or growth, like it looks like it's growing outside of the thyroid or with lymph nodes. Somebody that's not comfortable following it, or a patient that seems pretty non-compliant. Lastly, I want to talk about thyroid surgery because many of our cancers and some of our non-cancers are going to need surgery. For thyroid cancer, our goal is to maintain a low disease-specific mortality currently experienced by most patients, as well as reduce potential complications from surgery and any need for operation. And my patients, I try to give them a cosmetically favorable incision. Surgery performed by high volume surgeons, because it's been shown that surgeons that don't do as many of these have higher rates of incomplete resections, not as good outcomes. They're more likely to experience complications with higher costs and longer stays. So when we do surgery for thyroid cancer, there are three options, or sort of four if we include active surveillance. Then it's take out half of your thyroid, all of your thyroid, maybe with some lymph nodes, as well as possibly adding on a bigger neck dissection when needed. Most thyroid surgeries these days, except for very large thyroids, should be able to be done through some form of minimal access surgery, which either includes a small incision or some sort of laparoscopic approach. A thyroid lobectomy includes taking out half of your thyroid. And we do this for benign lesions that are causing symptoms, for diagnosis, for indeterminate nodules where we don't know if it's a cancer, and for small cancers less than 2 to 4 centimeters that have no evidence of spread beyond the thyroid. When we take out your whole thyroid, we do this for more invasive and larger cancers, if you have nodules or disease on both sides, if you seem to have more aggressive histology or the tumor seems to be growing beyond the thyroid. We add in a lymph node dissection only when we for sure know it's a cancer. And how big of a lymph node dissection really depends on your tumor, as well as sometimes surgeon discretion. As you can see, there are two kinds. There are the lymph nodes around your thyroid, and then there are the lymph nodes on the side of your neck. The lymph nodes in the middle by your thyroid can all be removed through your small thyroid incision, where the ones on the lateral side of your neck require us to extend your incision back towards the back of your neck, but generally we're able to do it in a neck crease so that it's cosmetically favorable. Sometimes many of you have heard that people have had to go back through for a second surgery. We only do this when we otherwise would have taken out the whole thyroid if we knew the cancer diagnosis beforehand. So we do this very infrequently these days. Who actually needs radioactive iodine after their cancer treatment? I'm not spending much time on this, but in briefly, if you have a low-risk thyroid cancer, remember the chart I showed you before? We do not give radioactive iodine for these patients. We have now shown that there's really no benefit for your survival or for recurrence for giving radioactive iodine. For intermediate risk patients, we sometimes give radioactive iodine, and when we give it, sometimes it's a smaller dose as opposed to a bigger dose, but that's kind of patient and tumor specific. Lastly, for high-risk patients, we definitely do give radioactive iodine because we have shown benefits in both survival and recurrence. So what are the take-homes? Thyroid nodules are very common. Most are benign. Importantly, thyroid cancer is very treatable and most patients are survivors. Most surgery for thyroid disease is now some form of minimal access surgery, and for certain conditions, there are actually alternatives to surgery. Here are some patient resources that are available on our website. Next, Dr. Redinger will be speaking to you about hyperthyroidism.
Hello, I'm Sarah Rettinger. Thank you so much for having me. I'm a clinical endocrinologist in Santa Monica, and I'm happy to be talking about one of the most common conditions that we treat as endocrinologists, hypothyroidism. So what is hypothyroidism? Essentially, hypothyroidism means too little thyroid hormone, sometimes referred to as underactive thyroid. As Dr. Goldfarb talked about, we have this amazing butterfly-shaped gland in our neck, which helps regulate our metabolism, our temperature, our digestion, our weight, and even our mood. So when this gland, either because it is itself damaged or attacked, or because it's not getting proper signals from the pituitary, can't synthesize enough of this hormone, T4, which is our main thyroid hormone and quite critical to our overall well-being. What is the epidemiology of hypothyroidism? Well, as I said, hypothyroidism is the most common thyroid disorder worldwide and in the United States. In the United States, the overall prevalence is about 4.6%. Now, about 4% of these are what's called subclinical, which we'll talk about, and about 0.3% of these are overt. Overt hypothyroidism is a full-blown hypothyroidism where patients are symptomatic and the labs are quite dramatically low. In subclinical hypothyroidism, the circulating amount of thyroid hormone is still normal, but there's evidence in the laboratory that a patient's pituitary gland is working quite hard just to maintain normal levels. There are about 5 to 8 times more cases of hypothyroidism in women and men, but because it's so common, we see many men and many women with this condition. I wrote right here that we'll talk about our normal values for each of our thyroid laboratories, but we have to remember that with thyroid hormone, more thyroid hormone isn't necessarily better. Each of our bodies has a natural set point for the amount of thyroid hormone that's best for us. As we get older, there is a trend towards hypothyroidism, lower and lower thyroid. We think that this is normal and that there's good reason for it and that it might be cardioprotective. So when we talk about our normal values, we just want to be careful. What are the causes of hypothyroidism? Well, in about 95% of cases, the cause is autoimmune hypothyroidism, otherwise called Hashimoto's. This means that the body is making antibodies that attack the thyroid gland or enzymes of the thyroid gland. This process can take a long time, years and years, or it can be very quick and take weeks. In general, this Hashimoto's runs through families, in particular mothers to daughters, but can show up spontaneously as well. So that's the lion's share of the cases we see. Patients can be hypothyroid from surgical removal of the thyroid gland, either for thyroid cancer, which Dr. Goldfarb talked about, or for Graves' disease, which Dr. Lin will talk about. Patients can be low thyroid from radiation treatment to their gland, again for Graves' disease or thyroid cancer. Patients can get inflammation of the thyroid gland after a viral illness. And we see this starting about now in the year, November, December, January. Coxsackie viruses in particular can be associated with thyroiditis and hypothyroidism. Many medications can induce hypothyroidism, in particular amiodarone, which is used to regulate heart rhythms, lithium, which is a mood stabilizer, and then immunotherapy, which is used for cancer. Historically, hypothyroidism had been caused by too little iodine. Now we mostly see this in the less developed world. Low iodine as a cause of hypothyroidism. In the US, all of our salt in packaged foods is iodinated. So we rarely see low thyroid from low iodine. We do see cases of low thyroid from too much iodine, since sometimes patients will take iodine supplements or iodine drops, which contain far supraphysiologic levels of iodine. So I probably see hypothyroidism from iodine supplements about once a week, and I rarely see patients with hypothyroidism from iodine deficiency in Los Angeles. The last two, patients can have destruction or damage to their pituitary gland, so their pituitary gland doesn't give off the proper signal to the thyroid gland. And finally, patients can be born without a working thyroid, and this is congenital hypothyroidism. Now all babies are screened for this and treated immediately right after birth with excellent effect, growing up completely normal. So who should be screened for hypothyroidism? It's somewhat controversial, but this is sort of a summary of our professional organizations, especially Endocrine Society, recommendations for screening. So patients can be screened, and all the screening is with a blood test. So patients can have a blood test, certainly if they have hypothyroid symptoms, which we'll talk about in the next slide. Patients who've had a history of thyroid surgery, thyroid radiation, of course. Patients who've had pituitary surgery or pituitary disease, and patients who are on immunotherapy for cancer will often have their thyroid labs checked as a matter of course every 4 to 8 weeks, depending. We do also check patients with history of other autoimmune diseases, so type 1 diabetes, celiac disease, or lupus. And patients with a family history of autoimmune thyroid disease, patients where their mothers, aunts, grandmothers have Hashimoto's. We would check those patients as well. I sort of issued this caveat to myself, which is that asymptomatic patients who do end up with positive blood screens, let's say on a routine visit with their primary care doctor, and the routine blood screens show up with some indication of mild hypothyroidism, we recommend holding on treatment, taking a breath, and rechecking in about 3 months. 50% of patients who are asymptomatic and feeling fine will normalize at 3 months and never need thyroid hormone. Again, it's only for patients who don't have symptoms. Patients with symptoms, we would screen and treat right away. So what are the symptoms of hypothyroidism? So they're somewhat nonspecific, and so we have to tease these out very carefully when we speak with patients. So the big ones are fatigue, an overall sense of grogginess, and there can be some memory impairment, and certainly depression or mild depression. This says shaggy hair, but patients can complain of lackluster hair and some hair loss, although hair loss is most often seen with hyperthyroidism, which Dr. Lin will talk about. In significant cases, patients can get a swollen face and swelling in other parts of the body as well. Patients can have rough or dry skin. In patients, again, with severe hypothyroidism, they can have an enlarged thyroid gland, or what we would call a goiter. Severe hypothyroidism can cause a slow heart rate. Even mild hypothyroidism can cause constipation and less frequent bowel movements. Again, dry skin. Some muscle cramps and paresthesias, but that would only be for patients that are very advanced, and we would hope to pick up all those patients before we got to that point. And then this is diminished potency and fertility, and where we really see that, some diminished potency, diminished libido in men, and then we see irregular menses in women. So patients who all of a sudden have irregular menses, thyroid would be one of the first things we would check. And not included on this list, but one that I think is quite helpful, is cold intolerance. Hypothyroid patients may feel cold. So how do we diagnose hypothyroidism? Well, first thing, as in all endocrinology, our diagnosis is based very much on what patients tell us and what our laboratories show. So the first thing is we always ask patients about symptoms, run through the list that I just showed you. We take a very careful medical history and family history to delineate the causes that we talked about, careful physical exam, and then blood studies. These are the main blood studies that we would use to diagnose hypothyroidism. So our most important are TSH and free T4. I'll show you a picture of where those come from. TSH, the pituitary signal to the thyroid, and free T4, which is a nice stable measurement of circulating levels of thyroid hormone. For patients that have a concern for autoimmune thyroiditis, which is quite often, or Hashimoto's, we just go ahead and check the patient's Hashimoto's antibodies. This is TPO antibody and thyroglobulin antibody. And this is a binary diagnosis. Either patients have antibodies or they don't have antibodies. They meet the threshold or they don't. So we can make the diagnosis of Hashimoto's quite easily, but just by checking the antibodies. This is a schematic to show you why TSH and free T4 are so good at diagnosing hypothyroidism and how we use them. So if we think about T4 being the main form of thyroid hormone that's secreted by the gland, of course, if T4, and in our case we check a free T4, is low, below the limit of 0.8 to 1.8, that's hypothyroidism. TSH, or thyroid stimulating hormone, is essentially a gas pedal, a go signal from the pituitary to the thyroid gland. If that level is high, over about 4 to 5, we know that the pituitary is having to work very hard to get the thyroid gland to produce thyroid hormone. So when TSH is high, that's an indication that something is not working well in the thyroid. Just a caveat again, the normal range of TSH can be controversial. We usually think of it as 0.4 to 4, but this value can go up, like we talked about, normally as patients get older. So although in a young person, we would certainly treat for a TSH over 4, as patients get into their 70s and 80s, a normal value may look more like 5, 6, 7, or even 8. And since we know that there may be cardioprotective benefit to running higher TSHs, we want to make sure we don't overtreat. So hypothyroidism, with most of the causes that we discussed, is not cured. If you have Hashimoto's, you essentially always have your antibodies for life. But hypothyroidism can be treated essentially in all patients, and we can treat patients in a quite nuanced way and change thyroid hormone very quickly to keep up with patients' needs. So hypothyroidism, patients with hypothyroidism live long, happy, healthy lives, have children, are athletes, etc. And in general, the safest way to treat is simply to replace the main form of thyroid hormone that the patient's own body would make, and this is called T4. So we have these different options for giving back thyroid hormone. Safest way, again, is by giving back this T4 hormone only. It goes by many names. Levothyroxine is the generic name. Some different brands are Synthroid or Tyrosint. They are all molecular copies synthetically made of T4, thyroid hormone. The discussion about T3 and combinations of T3 and T4 is an entirely different talk that could go an hour, but there are available commercial preparations of T4 and T3 combined, made up from essentially crushed up pig thyroid glands. These go by the name Armour Thyroid or Nature Thyroid. And are sold in the United States. And then sometimes, for some reasons, we choose to add on this thyroid hormone T3 alone or in combination with T4. And this goes by the name Cytomel or liothyronine. Are there side effects to treatment? Well, the only side effect is over-treatment. So too much thyroid hormone causes atrial fibrillation, a heart arrhythmia, and it puts patients at risk for osteoporosis. So when patients get put on thyroid hormone, we want to really make sure we're shooting towards that normal range and protecting patients from too much treatment. We follow up patients initially every 3 months, just with blood tests. We try to give longish intervals of at least 8 weeks to 3 months because the TSH, one of our main parameters of checking, is quite slow to change. And our follow-ups and our dose adjustments are based on, like in all endocrine, how is the patient feeling? Are there signs or symptoms of high or low hormone? And then we look at the laboratories and we use what the patient's telling us in the laboratories to think about adjustments and how the patient is doing. Once those patients are stable and their patients are on a stable dose of thyroid hormone, they can be checked once yearly by us, endocrinologists, or the patient's primary care doctor. And I just leave with this quote from Hippocrates with the directive to do no harm, because we do have so much over-treatment and over-diagnosis of hypothyroidism, especially in West Los Angeles. We want to be careful that we're just treating the patients that need to be treated and not over-treating them. Thank you very much. I will be available for questions after the talk, and I look forward to hearing them. Thank you so much.
Thank you, Dr. Redinger, for a great presentation. Next, Dr. Lynn will be talking to you about hypothyroidism.
Good afternoon. I'm Dr. Rose Lind, endocrinologist with the Doctors of St. John's. Today I'll be talking about hyperthyroidism. So what is hyperthyroidism? Hyperthyroidism is when we have an excess or too much thyroid hormone in our bodies. What are the symptoms of hyperthyroidism? Generally, you can feel like you are overstimulated or like you've had too much caffeine. Your metabolism may increase and you may feel heat intolerance, notice rapid unintentional weight loss, or have fatigue. You can also feel anxious or nervous and have difficulty sleeping. Your eyes may feel dry or gritty. Your neck may become painful, tender, or enlarged. Your pulse may be rapid or irregular or feel like it's pounding. You can also feel short of breath. Frequency of bowel movements may increase. For women, periods may be irregular. You may have shakiness of your movements, particularly noticeable in the hands. So what are the causes of hyperthyroidism? Graves' disease is an autoimmune condition in which your body can produce antibodies that target the thyroid. These antibodies target the TSH receptors and will stimulate the thyroid to produce thyroid hormone. Thyroid nodules can, in some situations, be overactive. This means that these specific areas of growth within the thyroid gland are producing thyroid hormone in excess, while the remainder of the thyroid gland remains under normal regulation. Thyroiditis is when the thyroid becomes inflamed and leaky. This leakiness causes thyroid hormones to be released from the thyroid without regulation while the inflammation is ongoing. In some cases, people may become hyperthyroid because of the medications that they are taking. Such instances might result from a person having significant weight loss, and then the thyroid dose becomes too much for their current body weight. So how do we diagnose hyperthyroidism? A clinical diagnosis can be made. This means that the doctor can do a physical exam and look at vital signs and conclude that hyperthyroidism is present. Some of the signs that a doctor may see on exam are exophthalmos, which is a forward bulging of the eyes due to inflammation of the eye muscles or enlargement of the eye muscles. Thyroid enlargement or a nodular bumpy thyroid can be detected on physical exam. Shakiness can also be noted on physical exam. Blood tests can be helpful, particularly as some people with hyperthyroidism will not have any symptoms. A typical pattern that is seen on blood tests would be elevation of the thyroid hormones, so high levels of T3 and T4, and a low or undetectable level of TSH. In some cases, your doctor may order thyroid imaging. A thyroid ultrasound can be helpful to detect enlargement of the thyroid or thyroid nodules. A thyroid uptake and scan may also be ordered. This is a test that involves a small dose of radioactive iodine, I-123, to measure and identify areas of hyperactivity within the thyroid. High uptake and high activity levels can be seen in Graves' disease. Low uptake and low activity levels can be seen in cases of thyroiditis. A thyroid nodule may be identified by a discrete area within the thyroid that is showing high activity levels compared to the rest of the thyroid gland. Finally, how is hyperthyroidism treated? We have antithyroid drugs, methimazole and propylthiouracil. These medications need to be monitored. Thyroid hormones need to be monitored as well, and doses of the medications adjusted down as the hyperthyroidism responds. In some cases, we will also use a beta blocker such as propranolol to treat the symptoms of hyperthyroidism, such as the anxiety and shakiness and rapid heart rate. Radioactive iodine is a treatment which uses the destructive properties of I-131 to specifically target the thyroid and permanently disable the thyroid from being able to produce thyroid hormones. The end result of radioactive iodine is hypothyroidism, which will be discussed in another segment of this webinar. We also have surgery as an option. In surgical management, a partial or total removal of the thyroid gland is performed. If the total thyroid is removed, the end result is hypothyroidism. If a partial gland is removed, such as for treatment of an overactive nodule, hypothyroidism may or may not develop.
Thank you, Dr. Lynn.
Okay. Thanks everyone for joining our webinar. I'm going to go through some of the questions that have been posted on the box. We did put in some answers, but I want to go through them so everybody can hear. First, I'm going to do these to our endocrinologist, Dr. Lynn and Dr. Redinger. Do you recommend that someone with hypothyroid or Hashimoto's see an endocrinologist?
Depends. If patients are feeling well and they have a long-standing history of Hashimoto's and the labs look normal, an internist is very well qualified to follow the labs and make little dose adjustments. If patients aren't feeling well or there have been some kind of changes in their dose requirements or they're having symptoms of high thyroid or low thyroid, that's a perfectly good reason to check in with an endocrinologist. So both.
Thank you, Dr. Redinger. Another great question. Can diet or complementary therapies help thyroid issues? I think this is a question that all of us get all the time. So I'll let my colleagues answer this.
Yeah, so I think Dr. Redinger addressed some of these in her talk. So we talk about things in the diet like iodine, which generally for those of us who live in industrialized area is something that we're almost never deficient in because it's so prevalent in much of the regular foods that we eat. So we really, in most situations, do not recommend any excess or reduction of iodine, except for maybe in specific instances of recommending certain treatments in thyroid cancer for a short period of time. Selenium is a something that is recommended at times and can be helpful for people who have Graves' disease and specifically ophthalmopathy or Graves' disease affecting the eyes. Gluten is something else that's also discussed. I don't know that there is a specific strong recommendation to avoid it in the society guidelines, but I do have patients who follow a gluten-free diet for a period of time and try to see if that helps. I would say in my personal experience, I haven't seen it make a huge difference when the patients come back to me and tell me that they've given it like a 3-month or so trial of eliminating gluten from their diet.
Thank you, Dr. Lynn. Yeah, it's definitely a question that I get a lot also. On that note, can the thyroid go from hyper to hypo? And I'm going to say yes, but if you guys want to talk a little bit more about that, go for it.
Yeah, so I guess, certainly when we treat hyperthyroidism, a couple of the options that we use to treat, which would be the radioactive iodine or surgery, we're actually intentionally trying to create hypothyroidism and permanently disable the mechanism so that hyperthyroidism doesn't continue to cause health problems for a person. Also, when we use medications to treat hyperthyroidism, if you're not following carefully and not adjusting the dose of medication, a person can have a very strong response and actually develop hypothyroidism, which we don't pick up until we do the next blood test or unless they really develop some pretty severe symptoms and tell us about that. And then I guess just to kind of follow up on that, there are some cases, not that common, but there are cases where there has been a person with a long-standing history of hypothyroidism who actually then presents with hyperthyroidism sometime later after a long history of being on thyroid hormones to treat their hypothyroidism.
Thank you. Oh, go ahead.
Excellent. I agree with everything that Dr. Lynn said, but I will say at the beginning or the initial presentation of Hashimoto's or any of the other inflammatory thyroid issues, either from medication or post-virus, the very first thing your thyroid can do when it's under attack is release thyroid hormone, like Dr. Lynn said. So those patients can start out quite hyperthyroid and then move into normal or low thyroid. And we see that a lot.
So with that, Dr. Redinger, since you did the hypothyroid talk, how common is thyroid disease with Hashimoto's? And will I know I have it in terms of symptoms?
So this is for the patient that has Hashimoto's. The question is, how often will the patient with Hashimoto's become hypothyroid? That's the question.
No, how often will they have eye symptoms?
Oh, eye symptoms. So that's interesting. So just with Hashimoto's, the eye symptoms would be more swelling in the soft tissue around the eye. And I actually don't know the prevalence of it. In particular, for it really depends, I think, on the level of hypothyroidism. So if patients are quite hypothyroid, I would expect to see some swelling, which goes away with treatment. For patients that are very well controlled, it's not that common, but we do see it.
And also, can you have a normal TSH blood test, but still have an issue with your thyroid?
So it's unusual, but one of the causes that we might see would be in patients who we know have a pituitary condition, because the pituitary gland is the gland that makes the TSH, and that responds very dramatically, I guess, or very easily to small fluctuations in the thyroid hormone levels, T3 and T4. So in patients with a pituitary condition, it is possible that the TSH blood test would be normal, and we would need to rely on another blood test, such as the T3 or more particularly the T4, to indicate a thyroid condition. Or in that case, I guess really it's more of a pituitary condition that affects the thyroid.
Okay, next. What are concerns that Graves' disease can become cancer? I guess I'll try to answer that one. Graves' disease itself is not going to turn into cancer. You can have them happen simultaneously. It's definitely much less common. Usually when somebody's hyperthyroidism, they have somewhat less of a risk of cancer with Graves', but we definitely see it that you can have both happen at the same time. I also want to go over a couple questions that I answered on in the Q&A box. Somebody asked, how is thyroid cancer monitored after surgery? We monitor you generally with blood tests, thyroglobulin antibody, and your TSH, which is really similar to what people do for prostate cancer when they monitor PSA. Most people will have an ultrasound at least one sometime after their surgery, and how many other imaging tests you have after that really depends on what your risk for recurrence is. And then there was another question about what are the risk factors for recurrence, and really that's totally dependent on what your pathology is. So your surgeon and your endocrinologist should hopefully go over your pathology reports with you, and they'll put you in a category of low, intermediate, or high risk for your cancer coming back. And we have some general percentages within that based on your specific tumor features of what your risk is. The next question is, because hypothyroidism slows your heart rate, is it safe to exercise?
Yeah, so when hypothyroidism is treated, it's safe to do everything. If someone was coming in with acute severe hypothyroidism, I would just have them rest for a week until we can give back their thyroid hormone. But someone who's treated and treated properly, no problem with exercise.
That's great. There's one other sort of a personal question here. a patient had a total thyroid for 12 years and has been on levothyroxine, is having a lot of symptoms, losing muscle mass, weight loss, hungry, fatigue, pinched nerves, and wants to know what they can do and are there any natural remedies to help this?
So for that patient, I think with different symptoms, I would love to see that patient in the office and really, really talk to him or her, because that constellation of symptoms sounds a little bit like hyperthyroidism or too much thyroid, especially with the muscle wasting and the weight loss. So I think that would be a patient that sounds like there could be something else going on, or perhaps the patient isn't on the right combination of thyroid hormone or isn't on the right dose of thyroid hormone, because we really expect our replacement should be as good as the patient's own thyroid. So for patients who've had thyroidectomy, we really aim to get them feeling great, and they shouldn't have long-lasting symptoms. So someone who's had a thyroidectomy, we want to make sure whatever the issue was, why they needed the thyroidectomy, cancer, all that's gone. There's nothing else going on. And then that we're optimizing the thyroid replacement, because patients should feel pretty well. And if not, we need to look into it.
Awesome. Thanks, Dr. Renninger. Another question came in. Can a person with hypothyroidism be taken off medication after years of taking levothyroxine?
So it depends what the original indication was, why the patient was put on levothyroxine. I see a lot of patients who were put on levothyroxine for one lab value that was off, and they never really got a diagnosis of Hashimoto's, but maybe somewhere in their lives, someone saw one TSH value that was off, and now they're on thyroid hormone forever and ever. And yeah, we can successfully wean patients off if they don't have another underlying cause for hypothyroidism. So we would check Hashimoto's antibodies if the patient doesn't have them, and we kind of look into the circumstances as to why the patient was put on thyroid hormone in the first place. I have a lot of patients that would like to wean. It's worth a try. We go really slowly, watch labs, see how the patient's feeling. But yeah, we do that a lot.
And on that note, how many days, if somebody's on a regular dose of thyroid medicine, how many days can they really be without it before it's going to start affecting them down the road?
It depends.
Yeah, so it's hard to say exactly how many days. So we look at something like half-lives in terms of how many days before like half of a certain drug or medication is eliminated from your system. So when I look at it the other way, for example, if I were to change and increase a person's dose, then I might say, let's wait 6 or 8 weeks before we see what your steady state is. So in general, I would say that if you were missing a day, or even if a person missed 1 day a week, they may not have any symptoms or notice any ill effects to their health, but we may start to see some not optimal values in their blood tests when we measure that. But I don't know if there's a really good, how many specific days a person could be off, but I would certainly say if you missed 1 or 2 days because you didn't have your medication, or you couldn't get your refill, or it wasn't delivered, that's not going to be harmful.
Thank you. So what if I get pregnant and I have hypothyroidism? Should I still take my medicine?
Absolutely, wholeheartedly, yes. And in fact, when patients get pregnant, even 4 weeks pregnant, right at the very beginning, patients need about 25% more thyroid hormone to support the pregnancy and make sure the fetus is getting enough thyroid hormone. So we absolutely want patients to take their thyroid medication, get their labs checked, and most likely increase thyroid medication. The developing fetus 100% needs thyroid hormone for good development, brain function. And so that is not a time to go off of thyroid hormone.
Yes, thank you. One more. Does a patient that has a former or recent diagnosis of breast cancer need to see an endocrinologist to check for Hashimoto's?
Not necessarily. There shouldn't be any increased risk of Hashimoto's just from having the breast cancer. No, not at all. They might want to be screened by their primary care doctor or oncologist just by getting a TSH level. I think that would be a very reasonable screen for patients with breast cancer. In general, we don't use immunotherapy for breast cancer, but patients on immunotherapy for other kinds of cancer will have their TSH checked automatically by their oncologist.
Thank you, everybody, for all these wonderful questions. You'll see up on the board our phone numbers to come and see any of us in the office, as well as an email that you're welcome to email for an appointment as well. We generally don't answer questions over email because we need to see you as a patient first from medical legal stuff. But you can look at all the information we've put on our website, call the office, and we hope that this was an informative webinar for you today.